Hello, my name is Jasmin. I will be presenting my case study for our clinical rotations during the summer. My patient was a male, 70 years old, 6'1", and weighed 189 pounds. This patient's chief complaint was shortness of breath. His admitting diagnosis was severe sepsis with acute hypoxia, respiratory failure, obstructive bacterial pneumonia associated with known cancer. So this patient was admitted for shortness of breath, where they found that the patient had obstructive pneumonia. His shortness of breath worsened even while on BiPAP. The patient's eyes were open, but he did not respond to any verbal stimuli. He was intubated while in the ICU. The patient's worsening encephalopathy and respiratory distress could be linked back to his pneumonia. Patient was bronched, where samples came back positive for yeast. Patient does not have family, so they are trying to get a friend to be a POA to start making medical decisions. Some of this patient's history is that he does have chronic bronchitis, COPD, is a current smoker, smokes about half a pack a day for the past 55 years, suffers from anxiety, depression, and difficulty controlling anger, arthritis, diabetes, dyslipidemia, and history of cardiovascular stress test. So the assessment with this patient, usually if they do have chronic bronchitis, they're known as the blue bloaters. Initially for this patient, I did see some flushed skin, so there was some redness to the arms and there was redness to the cheeks. The skin temperature was warmer than normal to touch. He was using his accessory muscles, but was not diaphoretic. He was breathing regularly, and he did have symmetrical chest expansion, but you could kind of tell that he probably did have hyperinflation within his lungs. There was no edema, which is something that you would probably see in this kind of patient, but there was no edema in any of his extremities. So here are some vital signs for this patient. This patient's heart rate was 102. His respiration rate was 17. His SpO2 was 91, which is pretty good. His blood pressure was 126/62, which is okay as well. Temperature was 99.5, which this is a lot better than what it was before. When he was admitted, he did have a temperature of over 102. The days before I got to see this patient, he was running a fever of 101 and 100.5, kind of in between there. So this was an improvement. His I's and O's, you can kind of see that he is retaining some of the fluid, and his output is significantly smaller than his input. We checked for edema and the patient did not have any. Lung sounds were audible rhonchi, kind of coarse diminished in the lower lobes. So for sure, this was a patient that we were constantly having to suction. Every single time that we suctioned this patient, it was just thick yellow secretions and a lot of it. Most of the time we would have to lavage this patient just because of the thickness of the secretions, just to make sure that we were getting as much out. So here are the anatomical alterations from our book Jardins on chronic bronchitis. So chronic bronchitis constricts the airways, especially in the bronchi. You can see the constriction of the bronchial smooth muscles as well. Because of the bronchial irritations, the submucosal bronchial glands begin to get a little bit bigger, increasing mucus production. The cilia function also starts to not work properly, which is probably why this patient was bronchhed multiple times, just to make sure that they got a lot of the mucus plugs within his lungs. And another common thing to see with these patients is the hyperinflation of the alveoli. Here are the anatomical alterations for pneumonia. Usually it's the inflammatory process that affects gas exchange. Some red blood cells and fluid pours into the alveoli, which causes effusions. If the infection is overwhelming, the alveoli become filled with these red blood cells, fluid, and leukocytes, which are there just to make sure to try to fight off the infection. And usually all of this stuff ends up causing consolidation within the lungs. So here are some lab results from this patient. His white blood count is a little elevated at 10.54, which is a lot better than what he came in with. I do believe when he came into the ED, it was a little over 13. So you can definitely see that the antibiotics that they're giving this patient are definitely working. His red blood count is a little low at 3.65. Hemoglobin also a little bit low at 10.2. Hematocrit is also low at 32.7. His sodium is a little elevated at 147. And usually the sodium is important for the cell membrane to function properly and kind of keep those pressures within the cell appropriate. Potassium is normal, which this is good because it's important for the maintenance of the electrical membrane potential. Usually an imbalance of this can lead to cardiac electrical impulses and neuromuscular activity. His chloride is also a little bit elevated, which this is important to keep the amount of fluid inside and outside the cell, just to kind of maintain proper blood volumes and blood pressure. So it's really important to make sure that this is within range. And this also helps kind of keep the pH of the body within range as well. His bun was in a normal range. Creatinine, normal. There was no albumin values in there. His glucose is definitely high at 160, which it is not uncommon since this patient does suffer from diabetes. His platelets are 203, which is normal, and his sputum did test positive for moderate yeast in the lower left lobe. His ABGs were 7.35 with a PaCO2 of 50, PaO2 of 150, and bicarb of 26, and this was at 70%. And this ABG was actually taken after he went from his PRVC settings of 600 with a respiration of 18, PEEP of 8, and 60% FiO2, and that was changed to PRVC of 600 with a rate of 20, PEEP of 8, and 70% FiO2. So some of the respiratory medications for this patient were Duonep Q6, Bravana BID, and Pulmicort BID, which is pretty standard for a COPD patient. Because of the pneumonia and the chronic bronchitis, these medications really are important for the patient to take, especially because with chronic bronchitis, you do have the constriction of the airways and the bronchi, and you do see the bronchospasms in these patients. Some of the non-respiratory medications for this patient, we have propofol just to make sure that this patient is not irritated while on the ventilator. Some fentanyl just to kind of cover some pain that this patient might be experiencing. For the pneumonia, we are going to have some vancomycin and meropenem. And we're going to have some Protonics just to kind of help with that GERD, especially because this patient does suffer H. pylori infections. And then we have Humalog, which will be to help with this patient's diabetes. So I found this really good table on pneumonia and bronchitis, and just kind of gives you some statistics of which sex it kind of is more susceptible to this, race, what kind of other conditions also are affected by this a little bit more than others. But it also shows you kind of like the symptoms to kind of differentiate between bronchitis and pneumonia, which one of the big ones is pneumonia does have fever. Both of them are kind of tied together with the cough. Chest pain is a little bit more seen in pneumonia patients. Chills are obviously more in pneumonia patients. And like a sore throat is more seen in bronchitis patients. The green sputum is kind of seen more in also bronchitis patients. For breath sounds, you can definitely see that bronchi is kind of a thing that happens in both about the same. Wheezing a little bit more increased in pneumonia. The heart rate is going to be a little bit more elevated just because of the fever that the patient runs. So here you'll kind of see that you'll see higher temperatures because of the infection in more pneumonia patients versus bronchitis patients. Respiratory rates are about the same. And then you definitely see a decreased and diminished breath sounds in more pneumonia patients than you do bronchitis patients. So here I have just two pictures of some x-rays. The first one on the left is going to be chronic bronchitis, which some of the things that you would notice would be a flattened diaphragm and increased intercostal space due to the hyperinflation within the lungs and the alveoli. So then on the right, you're going to see the bacterial pneumonia, which produces focal, segmental, and lobar pneumonia opacities. In our book, Jardin's, it says that lobar pneumonia is widespread and diffused alveolar inflammation and consolidation confined to one or more lobes of the lung. You could definitely see that on the patient that I had. His x-ray just showed bilateral opacities. So here's the MD interpretation. The chest x-ray and CT pretty much says some standard things like the ET tube was mid-trachea, left IG catheter with tip at mid-distal SVC, right upper lobectomy was stable, right apical pleural density, bibacillar hazy parenchymal density. The CT said that it demonstrated worsening lung cancer with increasing mediastinal lymphadenopathy, new bony rib metastasized, left side mediastinal mass seemingly encasing and narrowing the left pulmonary artery as well. Has left lower lobe reticular infiltrates that are concerning for possible lipidic spread and pneumonitis. So here are some connections that we can make after looking at lab values, x-rays, CTs, and everything combined. One of the first things that we can tell is for sure that the antibiotics are helping. We can look at that white blood count going from 13 to a 10.54, kind of reaching a little bit more of a normal range. A lower hemoglobin can be due to inflammation, due to the chronic bronchitis, the pneumonia, and of course the cancer. Low red blood count due to cancer causing the inflammation again, that decreases that red blood count production. And that also kind of goes hand in hand with the hemoglobin. Low hematocrit, usually due to malnutrition. So there's a lot of nutritional values that a person is missing. And of course, cancer can also contribute to a low hematocrit. Hypernatremia, it was slightly elevated, could be caused by the poorly controlled diabetes. Our chloride was also slightly elevated, and usually this just kind of means an electrolyte imbalance. This is, again, very important to basically keep the fluid within the cells and keep the liquid outside of the cells just to maintain that balance. So we also see that the glucose is also elevated. This could be due to tube feedings. It could be to medications. It could be to infection. There's a lot of things that really do play a role into not being able to control glucose. So that's why we also see that the person is also on medications to help with that as well. Some of the suggestions that we kind of had out there just as we got report, we did end up getting told that the patient's ABGs came back a little abnormal. So they were a little acidotic. Their PaCO2 was a little elevated at, I believe it was 68. So we just went ahead and recommended just increasing that respiratory rate to kind of help with that PaCO2 and bringing that pH level a little bit up. Their SpO2 reading was reading from 85 to 89% constantly, just kind of alerting. So we ended up just also bringing their FiO2 up, as well as the other thing that we were always making sure that we were doing was making sure that we were constantly suctioning the patient, because this patient did produce a lot of secretions. So some other suggestions that we would try to consider is, if the patient were to recover, teaching the importance and benefits of quitting smoking, making sure to let the patient know the importance of taking their medications for maintaining their COPD. These are very important, and it's really good to just go ahead and remind the patient of doing these things to prevent them from coming back or avoiding any further infections or anything like that. So some of the things that we could see was that the chest x-ray was slightly improving. It wasn't getting worse. Overall, the CT really emphasized the progression of the cancer and how it was progressing and compromising the lungs and other organs and bones. The patient's pneumonia was also getting better. We could see that with the white blood count decreasing, also seeing the patient's temperature decreasing as antibiotics continue to work. The severity of the patient's respiratory condition was that the patient's pneumonia infection got so bad that it increased encephalopathy and respiratory distress, that the patient had to get bronched, they had to get intubated. Of course, also the patient was producing a lot of secretions, making it hard for that patient to protect their airways. So the expected outcomes kind of in a short term would be probably starting weaning parameters on this patient once the infection is completely taken care of. Once the patient is extubated, evaluating the patient's mental status, also making sure that we have that POA on there just in case if anything were to happen, and see if the patient can make any medical decisions for themselves. As a long-term outcome, as of right now, the patient seems very sick. The patient has cancer that has metastasized to other parts of the body. Patient is unable to follow commands and seems to not be able to understand when talked to. So far from what we've read, what we've talked to doctors, their professional recommendation would be going palliative, or else just going comfort cares, just because of the patient's extensive disease progression to all of this.